Dr. Samara, we can hear you. I think you can just share your screen again, Dr. Samara, your presentation. Otherwise, we could hear you fine. Yeah.
Can you see that?
Yeah, we can see that. But maybe just the slideshow would be fine.
Yes. All right. Good morning, all. Ramadan Kareem to all. Maybe some of you might not know me. I'm Dr. Samara, pediatric specialist at AMH Rafa and Amaj. Today, I'm going to be talking about the sunshine vitamin. We all know it's vitamin D, from its metabolism to modern practice. We want to understand the sunshine vitamin and recent advances in deficiency management. Please feel free to stop me and correct me if I'm wrong. And if there's any questions, we'll keep them at the end. So key points to learn today is, we want to cover most of them. What is vitamin D and metabolism of vitamin D? And then we're going to go over to learn about the epidemiology and the importance of vitamin D deficiency and risk factors. Moreover, we'll go over clinical significance of vitamin D deficiency, and then we'll run over some recent guidelines and updates, including American Academy of Pediatrics and the Indian Academy of Pediatrics. So we all know vitamin D is also known as calciferol, which is a fat-soluble vitamin as part of the ADE compound. It is an essential nutrient which is stored in the liver and fatty tissues that requires dietary fats for its absorption. That's why it's fat-soluble. And it requires careful intake to avoid toxicity. That's why it's not easily excreted and can accumulate. So it is crucial for we can forms of vitamin D. There are two: animal-based and vitamin D2, which is plant-based. So vitamin D3, also known as cholecalciferol, is the form of vitamin D which is animal-based. So it's found mainly in animal products such as fatty fish, egg yolks, and liver, and also some vitamin D supplements. It is formed when ultraviolet B radiation of specific wavelengths converts 7-dehydrocholesterol, which is present in our skin, to a pre-vitamin D, which is subsequently isomerizes to vitamin D3. On the other hand, the other form of vitamin D, which is vitamin D2, also known as ergocalciferol, is found in plants' dietary sources, so it is plant-based, and most of our vitamin D supplements. So it is produced by fortified foods like fortified cereals, milk, and infant formula. Now, both forms of vitamin D, they are fat-soluble, so they are best absorbed when given with a fatty meal. In the body, the other form of vitamin D is converted to calcidiol, which is the 25-hydroxyvitamin D. It's the major form in our body, which is the storage form of vitamin D. It is formed in the liver and bound by vitamin D binding proteins and transported to the liver, where it undergoes a hydroxylation process to form the 25-hydroxyvitamin D. And this is the vitamin D that we measure in blood tests to determine vitamin D status. The fourth one is calcitriol, which is 1,25-dihydroxyvitamin D. This is the active form. and has a shorter half-life. It's formed in the kidney after 25-hydroxy vitamin D undergoes it is regulated by feedback. So whenever we produce less calcium, what I just mentioned. So there are two processes that go through. One is in the liver, and then, of course, the first one is in the skin, and then in the liver using liver enzymes. The hydroxylation process forms the calcidiol, which is the 25-hydroxyvitamin D. And then in the kidneys, it is circulates to the kidneys where it is forms the active form, which is calcitriol. Mm-hmm. Now, vitamin D is essential for our body and at its different states, mostly important for calcium absorption and bone turnover. Epidemiology, to 16 years reported a high prevalence of vitamin D deficiency, whereas 15% of them had a vitamin D insufficiency and only 6% were sufficient. What are the primary risk factors for vitamin D deficiency? Exposure, especially in adolescence, indoor lifestyle, excessive sunscreen use can actually prevent the conversion and utilization. And in modest clothing as well. Skin pigmentation, how does it affect higher melanin levels, reduce vitamin D production in the skin? That's why people with pigmented skin or darker skin, they are more prone to vitamin D deficiency, and they require higher levels of supplements. In obese children as well, vitamin D gets sequestered in adipose tissue. And lastly, environmental seasonal variations such as warm climates, such as in winter and fall, with less sun exposure, as well as urban living and living in high latitudes. Clinical outcomes of vitamin D deficiency. As we know that mild deficiency is asymptomatic. However, in chronic or in severe deficiencies can lead to significant nutritional rickets, which is in the form of bowing of the legs and skeletal deformities that are noted in children. Hypocalcemia can also present with muscle cramps, muscle weakness, and infantile seizures. Whereas extraskeletal health can also affect the outcome, as emerging evidence now links low levels of vitamin D to increased risk of recurrent respiratory infections, asthma, as well as type 1 diabetes and autoimmune disorders. What are the recommendations? Now, according to the American Academy of Pediatrics, for prevention of vitamin D deficiency, it is recommended that all infants shortly after birth receive 400 international units daily of vitamin D, or 10 micrograms daily. Whereas preterm infants, they require specific needs. For example, infants born then less than 1,500 grams, they are it is advised to start them on 400 international units daily, and those above 1,500 grams, as soon as they're tolerating full feeds, it is recommended to start them on 800 international units daily. Formula-fed infants, mostly those who are receiving low volumes of formula, less than 1 liter, they also need supplementation. Children 1 to 18 years is recommended to start them on 600 international units daily or 15 micrograms. Screening is not recommended for asymptomatic children. However, symptomatic children showing bowing of the legs or signs of rickets, bone pains, unexplained muscle weakness, it is recommended to screen them using the testing for 25-hydroxyvitamin D. Higher risk group as well, such as obese children, those with darker pigmentation or limited sun exposure, those with celiac or malabsorptive disease as well, and children on anti-epileptic medications or steroids, long-term steroids. It is recommended to screen them. Based on the recommendations from the Pediatric Endocrine Society, the deficiencies are divided into 3 forms. So we have severe deficiency, which is levels of less than 12 nanogram per milliliter, and then insufficiency, which is 12 to 20, and the sufficiency is 20 to 100. So when we are supplementing the vitamin D, we are aiming at sufficient doses. So any doses, any levels of the 25-hydroxy vitamin D of 20 or more. That's our main aim. Treatment regimens available involve 12-week loading phase using cholecalciferol, so the vitamin D3. Why are we using vitamin D3? Because it has a longer half-life. It is well absorbed, better, more effective than the vitamin D2 at raising levels. So infants less than 12 months, we start them on 2,000 international units. This is the treatment dose, not the prophylaxis. So treatment is with 2,000 international units or 50 micrograms daily for 6 to 12 weeks, then followed by the maintenance dose of at least 400 international units. Daily dosing are more recommended than weekly doses. However, children who are not, they have poor compliance or they're not tolerating daily doses, we can start them on weekly doses, but above 3 months of age. On children above 12 months of age, we start them on 2,000 international units daily for 6 to 12 weeks, and then also followed by maintenance dose, 600 to 1,000 daily. Alternatively, so we can use the weekly, once a week dosing for 6 weeks, which is giving 50,000 international units once a week for 6 weeks, and then followed by maintenance dose. Now, high-risk children, those with obesity or malabsorptive disease, or those on anticonvulsant medications, that impact the vitamin D metabolism. They require higher replacement doses, almost 2 to 3 times higher than normal children. So we can start them on 6,000 international units, followed by the higher maintenance dose. Those children with established rickets, so severe deficiencies, also need higher treatment doses. More than 1-year-olds, we start them, 1 to 12 years old, we start them on 3,000 to 6,000 international units, and children over 12 years at dosing of 6,000 international units daily. There's something called the STOS therapy. STOS therapy is a very high, single high dose bolus of 100,000 to 600,000, which can be given orally or IM. And this is given for children with severe compliance, so poor compliance to oral medication or daily dosing. It is also recommended to add in calcium supplementation, which is essential for children with rickets, to prevent hypocalcemia or hungry bone syndrome. Then maintenance, we start after the 12-week treatment. we put them on, we transition to a maintenance dose to prevent recurrence. So general maintenance is, as we said, 400 to 600 international units daily for all children. And higher risk groups, they require a higher maintenance dose of 800 to 1,000 international units. Now, infants who are breastfeeding should start on 400, and formula-fed infants only need supplements if they are consuming less than 1 liter of fortified formula. It is also encouraged to have sunlight exposure at least 10 to 15 minutes a day, exposing the full face, arms 2 to 3 times a week, and consumption of fortified foods. Monitoring, how we monitor the after treatment. Now, there are 2 dosing forms. So as we mentioned, vitamin D3 and vitamin D2. It is more recommended to give the vitamin D3 due to its longer half-life and it's more potent. And it has a better option given using a single large dose. They're in the liquid given in high doses, 50,000 international units, which are given as weekly dosing. What are the recent advances? I reviewed some of the guidelines, 24 Endocrine Society guidelines. It is now, it's moving away from universal screening. So we are no longer screening for healthy children for vitamin D levels. However, it is recommended to start empiric supplementation. So we do start the supplementation without doing the blood tests for all children from age 1 to 18 years to prevent rickets and reduce the risk of respiratory tract infections. Also, empiric supplementation during pregnancy is now strongly suggested to lower the risk of preeclampsia and preterm birth. The Indian Academy of Pediatrics guidelines also recommend for starting infants on 400 international units per day as soon as after birth, and 600 international units for older children 1 age to 18 years. Prioritizing natural sun exposure is very important. Treatment, like we mentioned, this is according to the Indian Academy of Pediatrics, oral cholecalciferol for patients with severe deficiencies and rickets. To start them, oral cholecalciferol daily at 2,000 international units, those under 1 year, and 3,000 international units daily for over 1 year, for 12 weeks. Or the alternatively, which is less recommended, the 60,000 international units per week for 6 weeks. It also advises adequate dietary calcium, 250 to 500 milligram per day for infants, and 600 to 800 milligram per day for 1 to 18 years. Sunlight exposure, like we mentioned, now, high-risk groups, children on anticonvulsants, steroids, or with chronic illnesses need higher doses. Obese children also require 2 to 3 times higher doses, like we mentioned. Universal vitamin D supplementation is not recommended in childhood pneumonia, diarrhea, TB, HIV, and non-infectious conditions like asthma or atopic dermatitis. Now, the American Academy of Pediatrics supplementation guidelines also advises of the same, almost the same as the Indian Academy. Treatment is also the same. Infants, 1,000 to 2,000 international units daily for 6 to 8 weeks, and adolescents 2,000 per day, or 50,000, alternatively 50,000 international units weekly. Now, vitamin D toxicity is defined as serum 25-hydroxyvitamin D more than 100. So with hypercalcemia or hypercalciuria. So the normal levels are up to 100. Anything above 100 can cause toxicity. Normal upper limit for serum calcium from birth to 3 months, as we know, is 11.3. And at 3 to 6 months is 11.2. And then 6 to 12 months is 11.3. Now, the normal limits for urine spot calcium creatinine ratios by age up to 6 months, you can see is less than 0.8, and 6 to 12 months is less than 0.6. Serum parathyroid hormone levels will also be suppressed in cases of vitamin D toxicity. So it's one thing to monitor as well. New advances and non-skeletal benefits of vitamin D. Some research about the immune system. Recent guidelines suggest that supplementation with vitamin D may help reduce the risk of respiratory tract infections in children, as well as research now is ongoing to explore the vitamin D's potential role in managing conditions such as asthma and sickle cell disease, as well as involvement in type 2 diabetes. How does it involve in type 1 diabetes? Studies suggest that vitamin D might reduce the risk of progression to type 2 diabetes in high-risk individuals. And supplementation during pregnancy is increasing now to suggest reduced risk of complications such as preeclampsia and preterm birth. So in type 1 diabetes, prolonging vitamin D has a role in prolonging the honeymoon phase. So it can protect insulin-producing beta cells in a newly diagnosed diabetic and potentially extend their natural insulin production. It also has some effects on glycemic control. So supplementation has been shown to improve the HbA1c levels and fasting blood glucose in diabetic children. Now, early prevention, supplementation in infancy also has been linked to significantly lower the risk of developing type 1 diabetes. Maybe we can get some more info on that from Dr. Khadija. I don't know if she's available. Can reduce the exacerbation of severe, and research also shows vitamin corticosteroids. So as it triggers the production of antimicrobial peptide in the respiratory airways. Some research also suggests that it reduces the risk of recurrent respiratory tract infections in children, and it has immune response in common childhood viruses such as rhinovirus and RSV. In preterm care, recent 2025 trials suggest that certain supplementation levels are more effective than others at correcting deficiency in preterm infants without the risk of toxicity. And now new focus on maternal supplementation during the third trimester to reduce the risk of biochemical rickets in newborns. So the main takeaway is that vitamin D's role is evolving from just a bone nutrient to a more critical immune metabolic regulator for the next generation. Thank you very much. You have any questions? That's the end of my presentation. Open for any questions.
Dr. Samara, thank you. Thank you for the good presentation. Anyway, the insufficient range, you changed from 20 to 30 to 20, is it? Previously, we were telling 20 to 30 is the insufficient range and 30 onwards is the normal sufficient range.
Yeah, insufficient is 12 to 20, and then the deficient is anything less than 20. Sorry, deficient is less than 12. Insufficiency is 12 to 20. So you're aiming at maintaining 20 nanogram per milliliter.
Just a question on that, because on the one that we get as part of our deficiency says that the blood report we get, I think it's the next slide that you have. We have those values on as the level for deficiency and insufficiency. The very next slide after that one, I think that those are the ranges we have as part of our lab. Yeah, I think this is the one that we have from our lab. Less than 12 would be deficient,
Yes.
with up to 30 insufficient, and more than 30 sufficient.
This one is according to the Pediatric Endocrine Society.
And
This
the
is our
second,
lab.
You should
okay.
note there are two different units. So what is the rationale behind calling something insufficient, deficient, sufficient? What's the basis? There are three
more
different levels.
Yeah,
Why are
deficient
they
is more
three different? Yeah.
and the clinical manifestations of rickets. Insufficient, those who may be asymptomatic. So, yeah.
Yeah, it is the deficiency and insufficiency are based on the physiological stress that vitamin D causes. So we are not supposed to just do vitamin D levels. It is always supposed to be twinned with calcium, phosphorus, alkaline phosphatase, parathormone, PTH. So we should keep this in mind, meaning any discussion with vitamin D and rickets is incomplete without adding these metabolic parameters in our assessment. What happens in insufficiency is the parathormone level. This is the point where secondary hyperparathyroidism is triggered. That's until which time you can manage with lower levels of correction. And if it has crossed the parathormone trigger, which means we have to be vigorous. That's the protocol you said, doubling up or tripling up the dosing of vitamin D. So vitamin D manifestations remain asymptomatic beyond a point. Calcium, phosphorus metabolism affected. Beyond another point, parathormone metabolism affected, and that's when it becomes insufficiency. So bone health, the physiological stress, that's a reason they could have simply made it two cutoffs, one when you start correcting. When you start correcting, vigorous correction is when you do this. And what's the rationale of repeating? When do you recommend after correction, repeating the levels? And what's the dosing of calcium? We didn't talk about the calcium at all. So calcium correction, and do you repeat after supplementation? What's the recommendation there? And what is vitamin D dependent rickets based on these metabolic parameters itself? And what happens if levels don't get corrected even after proper compliance ensured, and then you have managed correction? Do you repeat the first question? And then if it is not corrected, what next? And what if parathormone is on the opposite direction than you expect? These are a couple of caveats you'll have to discuss. Am I audible? Are you there?
Yes.
Yeah. Do we repeat? What's the recommendation when after the proposed duration of supplementation or correction?
So
The
it is
levels.
recommended it's 3 to 6 months after starting the treatment, and for calcium to monitor 1 month, at least 1 to 2 months after starting the treatment.
And what about the PTH levels, calcium, phosphorus, alkaline phosphatase? What's supposing your parathormone after duration of correction, if you repeat and the level is not corrected?
So therefore, you need to increase the dose. Yeah, including you check for parathyroid. So you do a full bone profile, including parathyroid, alkaline phosphatase, phosphorus, serum calcium.
Yes, when we are doing vigorous correction, it has to have a baseline calcium, phosphorus, alkaline phosphatase, and parathormone estimation. In the outset, if parathormone is not elevated, then you will have to think of endocrine causes. And after full supplementation,
Rickets.
yeah. So if parathormone is elevated and vitamin D not corrected, it becomes a vitamin D dependent rickets. You'll have to maintain a high dose correction for a longer time and monitor based on these levels. What's the role of 125 dihydroxy vitamin D and what does it convey? So when
It's the active.
yeah, sorry, yeah.
It suppresses the parathyroid release and reduces phosphate absorption. That's why it acts like an osteoclast activation and bone resorption.
Yes. Do we assess it? When do we assess it? And what does it convey? As a routine evaluation, you do not do it. After a full supplementation, if there is poor response, you will have to vitamin D resistant rickets. This becomes at that time you need to assess, and there are two classes in that vitamin D resistant rickets. So that would require evaluation of 125, where 125 is high is one category. These are genetic causes, where 125 is normal is another category. And again, the treatment goes in different lines in both of these categories of rickets. So normal dosing, if parathormone high, you will have to do double dosing or triple dosing as you initially started on vigorous treatment. Reassess on these vigorous, if you're asymptomatic or normal dosing, reassessment is not required. And the role of magnesium, sometimes when you're doing rigorous supplementation, if you're still having non-skeletal manifestations, there is a possibility of co-deficiency of magnesium along with calcium. So you will have to assess that and correct that also. That has a greater impact on the systemic manifestations on the cardiac, on the skeletal muscles, etc. So these are a couple of things we'll have to bear in mind when we are doing vigorous treatment with vitamin D. And a note on toxicity, no matter, that's why the STOS regime or high dose regime do not really manifest with toxicity. We do have situations where a couple of kids have come with overdosing, accidental overdosing, self-consumption and such. It really is not very easy to cause high toxicity manifestations. You'll have to, but it's a prolonged monitoring that you have to do if such encounters are seen. You'll have to ask them to revisit for calcium assessment, day 3, day 7, day 14. The manifestations are surfacing in that time profile. So toxicity doesn't really happen as a one-off and immediate thing, even with very high doses. But prolonged, as it's a fat-soluble one, stored and released, chronic hypercalcemia manifestations can happen. So you will have to, in such situations, monitor 3, 7, and 14 days on the stipulated regimen to monitor toxicity. That's from my side. So we'll have to actually make that a formulated way of managing when we are managing high dose and vigorous replacement of vitamin D with the eye on calcium phosphorus, alkaline phosphatase, and PTH. And the prescription for solar exposure, there are guidelines. Different skin types, as you said, there are biologically classified skin types. And for Bahrain weather, the average, regardless of the season, it is said mid-afternoon, which ranges between 11 to 1, 15 minutes arm face exposure is sufficient for stimulation of biological vitamin D production. So that is the rationale of designing our school uniforms and school breaks, apparently. And this is a recommendation that necessarily needs to be followed. You can suggest that if there are certain, as you suggested, modest dressing and guidelines, just hand exposure, the short sleeved and face exposure, 15 minutes, 5 days a week exposure. There are guidelines for different solar inhabitation for exposure time. Thank you. That's all from my side.
This is Dr. San. I just had one question more, Dr. Samara. Is there any particular reason why the AAP recommends 6 weeks of supplementation, whereas the IAP recommends 12, double the amount in terms of
I think
treatment?
it's more, it depends on the prevalence of the environment. So it's more prevalent in India. I think that's the difference here.
The universal guidelines go for 6 weeks for reassessment for deficiency. When we are doing vigorous treatment, that is double normal dosing, the break at 6 weeks, and it's a duration of 12 weeks.
Again, Dr. Vinita, 12 weeks. So normally supplementation for treatment deficiency, we give it for 6 weeks and then go back on maintenance doses post 6 weeks.
Correct. That is asymptomatic and low stress.
Yeah.
High stress categories, you do reassessment at 6 weeks and continue treatment for 12 weeks.
So
Then
high stress, you mean all those conditions where we have
high parathormone along with the vitamin D low levels. Yeah. And all the high risk categories, it's continuous treatment. It's double maintenance as a continuous supplementation or treatment, however you want to call it. there was no inclusion of liver diseases and renal diseases. These are the major chunk actually, the chronic renal diseases and the liver diseases, apart from the malabsorption, obesity, and anti-seizure medications.
And then another one, our maintenance doses, currently our two formulations of vitamin D are 400 and 500. So if we give 2 drops, it'll be 800, or if you give 1000. So preferable to stay on 500 per day then for maintenance?
Yeah, and recommend dietary intake also. This is overall intake. Dietary intake does contribute to some amount of vitamin D intake. The routine ambient diet does have vitamin D. So a 500 would suffice as a maintenance for average child diet, like fortified milk they consume. Then egg on a routine basis
Yep.
does have almost recommended dietary intake. So maintenance as medication we can supplement apart from solar exposure and dietary intake as well. So we can keep it marginally cumulative dosing.
Dr. Sana, what was that for 400 and 500? High D is 1 drop is 400.
Yeah,
Ostat.
Ostart is one.
Ostat. Okay. Okay.
Yeah, so that's why I was saying that if we give 2 drops of high D, it'll give you 800. So we're going over.
Presently, high D is not available. Is that the drugs?
Yeah, high D is currently not available. Only Ostart right now. Yeah.
Is it? Since when? We have stocks.
I think since yesterday. As in yesterday was the
Actually,
day.
for the last few days,
couldn't-
it is not there. They blocked it actually. Then they were opening when we
Ah,
were.
okay.
One more
Maybe
question,
so.
Dr. Samara. 25,000, the soft tools now we are giving, but they are not mentioning, say, even the treatment for deficient cases mentioned as 60,000. Not at all 25 is coming in this. So is it safe to give 25,000? Because some cases, depending on the age and the range, we are giving them 25,000.
The Academy of Pediatric
The
Academy
weekly
suggests
regimen says 50,000.
up to date is 25 to 50,000.
So if we give the flapules, the 25,000 flapules, if we give 2 flapules in a week, that'll be 50,000 for 6 weeks. Then we can do that way as well.
Yeah.
Yes.
We should start giving 2 in spite of 1.
Yeah, I think then 50,000 per week. So 2 flapules. Yeah.
Oh, they recommend 2000 daily means weekly is 1 should be fine, right?
Yeah, the recommendation is 2,000 per day or 50,000 week. It's not that it adds up to it, but then the cumulative dosing, considering the pilferage loss, processing,
Yeah,
and all
madam.
that.
But 2000 daily is 7 and week should be somewhere near 25, but then they jump to 50.
That's the thing. The regimen doesn't mean that it just adds up.
But either or more than 3 months old, as per what we've
Correct.
been saying,
Yeah.
we can do either or.
It
So
is at 6
2,000.
months. I think they pushed it, the newer recommendation, to 6 months. To not try weekly regimens under 6 months. This is the later recommendations. I'm not sure. 3 months used to be previously. Until 6 months, do not try it. And always, if you're going for a higher dose regimen, assess the status of calcium phosphorus for younger age specifically. You need to assess the background metabolic status always.
Okay. So calcium, phosphorus, along with your PTH at the
Alkaline
same time.
phosphatase as well. And after reviewing, to classify if the treatment to be complete and shifting to maintenance, it is necessary as well. If it has been vitamin D dependent, you need to sustain the management. So that decision you can make only after this reassessment. And if it is resistant, or if parathormone is to begin with low, it already guides you to a different category of rickets. That is also something you will be aware of.
How do we
Yeah,
supplement? Sorry.
sorry,
Yeah.
just the calcium supplementation that we have here in our hospital. Do we know how much is in the calcium syrup that we have?
We
How
have
many milligrams?
osteocare, I think it's 500. Osteocare, I
Per
think
5
what we
ml.
have is osteocare, yeah.
5 ml.
It's in and out. Sometimes it's there, sometimes it's not there, but does also have vitamin D, but negligible maintenance proportion, I guess.
So if we're not treating for rickets, let's say we're not treating for rickets, but we're treating for deficiency only, vitamin D plus calcium, so treatment doses, calcium in maintenance, and assessment of the calcium phosphorus alkaline phosphatase PTH.
Yeah, that you're not calling it rickets based on the levels of vitamin D, again, along with calcium phosphorus, alkaline phosphatase. See, then it becomes radiologic rickets also. That is, you'll have to see the growing and splaying and widening of the epiphyses and such. That becomes a full-blown rickets. If there are no radiological manifestations but calcium phosphorus alkaline phosphatase in the requisite direction alteration and the parathormone increase, it's already physiological stress, which is rickets, biological rickets, which is not manifested. So you have to go full scale like rickets manifestation. If you have a level which is like a deficiency without parathormone elevation, you can be managing like non-vigorous management of vitamin D deficiency. That is a course of 6 weeks, need not do double correction and such. So there the guidance from parathormone, you get that. Like calling it rickets or non-rickets would be based on that as well, apart from the radiological manifestation.
So, Vanita,
Yes,
hello.
doctor. Yeah.
Yeah. If vitamin D is low and there are no manifestations of rickets, do we need to supplement calcium or just vitamin D?
Vitamin D, they say along with high dose vitamin D, calcium is necessary. Otherwise, you will induce hypocalcemia. You will have to give calcium.
What is high dose? Like you mean like 50,000 you mean, or like normal daily 2,000?
Correction. Any correction is a supplement, it's not required when you're doing correction. That is treatment, you have to do calcium.
Yeah, madam, but they 200 mg per day, they roughly get from 2 cups of milk.
When you're doing vitamin D deficiency management, I'm saying, you will have to add calcium treatment. And it is said magnesium levels also you have to assess,
Mm.
That we
which
haven't
is
been
all
doing that.
routinely we are not doing, but calcium is baseline you will have to do. And along with vitamin D correction, you'll have to do calcium maintenance.
Dr. Vanitha, how we supply this phosphorus and magnesium and all through multivitamin or separately? Is it available?
No, yeah. No, this osteocare, whatever medication you have, will be phosphate salt of calcium.
Okay, that is enough. Magnesium is separate.
Magnesium, in addition, if there is deficiency, you will have to get an additional magnesium preparation. They say
What
it
about
can.
vitamin K2?
Vitamin K2, if associated, it is generally an adult manifestation that is as a co-manifestation of deficiency. So they are marketing vitamin D and K2 together. And K2 is needed in osteoclast performance also. So that's why that is not really in the recommendations of pediatric guidelines. But it is a recommendation already in adult guidelines to avoid osteopenia and osteoporosis. It is recommended as a co-administration with K2. The final metabolic transformation of active formation of vitamin K requires vitamin D. So they are co-dependent vitamins, vitamin K and vitamin D, and they are both necessary for bone production. It's not just vitamin D. So in that sense, they have and very minute doses like a hormonal dose in the body, it is required. So it's a recommendation, I think, beyond 50 years or beyond 60 years to supplement both K and
Recently, I had a patient, a 12, 13-year-old girl. Her vitamin D level was 3 on testing. Okay. So I did not do calcium, I did not do phosphorus, I did not do alkaline phosphatase or PTH. I just gave her 50,000 units per week for 8 weeks or so. So what should I have done in that case?
Now that you've done that, we see 6-week pre-assessment, you will have to do this. So just see if this could be vitamin D dependent rickets, if there is alteration, if there is biological benefit of vitamin D which we have given, or if there is any physiological stress at all. Sometimes they live without much physiologic change.
Yeah, because they say they come back after 6 weeks, they repeat, they say there's no change in level of vitamin D. I've been taking this much vitamin D and there is no change. So
exactly. So in such sense, we'll have to see all the 4 profile. The PTH will tell if it is vitamin K, vitamin D dependent rickets or resistant rickets. So that will guide us to manage further. So at 6 weeks, if we had baseline, we will know the direction of change. Since we don't have a baseline, we still have to make a decision at that juncture.
Now, she must have probably taken just 1 capsule because this patient came a week ago.
Yeah.
So should I call them in to do
Now,
these tests?
So in between, we cannot make any decision change. We can do it at 6 weeks. Now, dependent or resistant, we will get to know. Based on that, we'll further manage her.
And should this patient have been given calcium supplementation as well?
Yeah, now we can start it.
Yes,
that's fine.
Yeah.
Okay.
You're not supplementing. So any treatment is advised to start calcium as well.
Okay.
That's right. Yeah.
Okay. Thank you.
Thank you, Dr. Samara.
Thank you, Dr. Farid.
Bye, everybody.
Thank you, Dr. Vanita, also.
Bye. Thanks.